Okay, good evening and welcome to today's session. My name is Damaris Modeu. I'm a clinical nutritionist currently at Gaishanjiro Catholic Hospital, studying renal specialty and the Nutrition and Dietetics Academy. I'll be taking you through the topic of mineral bone disease in chronic kidney disease. Feel welcome. In case of any questions, kindly will be ready to answer you at the end of the session. So we'll have different objectives. By the end of the start of this session, it's important to understand what is the meaning of mineral bone disease in CKD. So also understand what's the relationship between CKD and the mineral bone disease. How does it come along? What are the causes? What are the complications, signs and symptoms? How do you get to diagnose that a patient has mineral bone disease? The way forward, after now you've been given the diagnosis, what's the way forward? How do you manage the patient? You're also going to be able to get an idea of how bone formation comes along, and I hope you're going to be able to learn a lot. So basically, CKD or chronic kidney disease is a worldwide health problem affecting 5 to 10% of the world's population, and the majority of these patients are at an increased risk of developing disturbances of bone and mineral metabolism. These disturbances lead to a constellation of bone lesions, which was previously referred to as renal osteodystrophy. I guess most of the people don't know mineral bone disease, but it was changed. It is no longer referred as renal osteodystrophy, but now it's referred to as mineral bone disease. So unfortunately now the renal osteodystrophy term does not encompass the important extraskeletal manifestation. Therefore, to address those drawbacks and accommodate the extraskeletal manifestation, the KDIGO, which is the Kidney Disease Improving Global Outcomes Foundation, initiated a controversies conference with the aim of providing a global acceptable definition and classification system for renal osteodystrophy. The workshop recommended a broader term, which is now the mineral bone disease. We initials is CKD MBD for the systemic disorder of the mineral and bone metabolism due to CKD. So mineral and bone disorder in CKD is a disorder that can affect bones, heart, and blood vessels of a person with CKD. Mineral and bone disease occurs when the kidneys are damaged by the CKD and cannot be able to filter blood and regulate hormones the way they are supposed to function. I guess in the previous days we have been able to understand into deeper concept what is CKD and how now the kidneys are affected to the extent that we cannot be able to have the normal functioning of the body. Then the hormone levels and levels of the minerals such as calcium and phosphorus then become imbalanced, and then which causes the damage. So at the end of the day, what now is CKD-MBD or chronic kidney disease mineral bone disorder? It's a systemic disorder of the mineral and bone metabolism due to CKD, manifested by either one or a combination of the following. One, it's abnormalities of calcium, phosphorus, PTH, which stands for parathyroid hormone or vitamin D metabolism. Two, abnormalities in bone turnover, mineralization, volume, linear growth, and strength. You're going to understand much better that when it comes to bone development, excuse me. Then thirdly, we have the manifestation of MBD is vascular and other tissue calcification. We have said that previously renal osteodystrophy was the term that was used for mineral bone disorder. So what did it mean, or what does it mean, and why was it abolished? It means an alteration of the bone morphology in patients with CKD. So it is one measure of the skeletal component of a systemic disorder. So you can find that now you can be able to understand well why it is no longer used, but because it's just a one measure. Now we needed a broader cover to be able to elaborate and cover all the different disorders that are there in CKD affected by minerals imbalances in the body. So on to the relationship between the kidneys and the bones. It's very important. At the end of the day, even if you don't maybe grasp anything, it's important to understand the relationship. So in case you be able to see different signs and symptoms as we later go on, you understand where does it come from or what has brought it on board. So your kidneys play an important role in maintaining healthy bone mass and structure, which is by balancing calcium and phosphorus levels in your bodies, activating a form of vitamin D that you get from the food and turning it into a form called calcitrol that your bones can use. Thirdly, the kidneys remove extra phosphorus from your blood by excreting them, which is passing them through the urine, then also sending phosphate and calcium back to the bloodstream from the kidneys and bones where there is need. What are the causes of mineral bone disease? When the kidney is damaged from the CKD causes, it leads now to mineral bone disorder because the damaged kidney do not properly balance the mineral and hormone levels in the body. So the damaged kidneys now, we have just tackled what do the kidneys do? So now the opposite happens. So the kidneys stop converting the calcidiol to calcitrol, which is the active form of vitamin D. Then they also stop removing excess phosphorus from your blood, triggering your blood to pull more calcium out of your bones, causing them to weaken. Also, when your kidneys are damaged, your parathyroid glands, which are located in the neck but are not related to the thyroid functions, they release parathyroid hormone into your blood to move calcium. Now, when you have excess phosphorus in the body, you find that the body tries to find calcium. Where is it going to get the calcium from, and how does that happen? So the parathyroid hormone moves into the blood to move calcium from the bones to restore it into your bloodstream. But this response also starves the bone, which much need the calcium. So you find that the body is no longer functioning properly. So whatever is high in the blood stream is the phosphorus. Hence the calcium is low. The body, to compensate that, you get that the parathyroid hormone is produced. After production, it comes and now facilitates the move on have enough calcium, they are weakened. So I'm going to cover the different complications of CKD and it slowed bone growth and bone deformity. You find that slowed bone growth happens especially when it comes to children who have CKD. They are in early stages because it doesn't take long for the stage 4, stage 5. But for children, stage phosphorus is less calcium in your blood and with the release of parathyroid hormone by your parathyroid glands. So parathyroid hormone moves calcium out of your bones and into your blood. The loss of calcium can cause your bones to have more harm. So the complication now comes along by bringing about slowed bone growth, which lead to short stature that may remain up to adulthood for these children. Secondly, you find a deformity, sometimes called renal rickets, in which also there is an increased likelihood of bone fractures. I guess this is just self-explanatory according to what we have explained about it. Because once the bones no longer have calcium, they are weak. So what is going to be the result? The fractures are going to be easily found for these children. Then another complication now, because we are talking about the bone fractures. So how does it come along? So because of them being weak, the thinning, so it is the development has been hindered because of CKD. Then if the bone was supposed to, because our bones gradually develop and as we continue growing, even if we reach into adulthood, the bones still continue growing depending on the exercises we do, the muscles that are the fat that is deposited along there, it determines the development. So you find if a child has CKD, that will bring about MBD. So MBD will result to the thinning and weakening of the bones. The joints of the bones will become very, very painful for these people. Then also there's a risk of developing low bone mineral content called osteoporosis. And then if it is severe, osteoporosis may increase your likelihood of now the fractures and broken bones. Another complication is heart and blood vessels problems. So you find mineral bone disorder cannot only harm your bones, it can also increase your risk of heart attacks, strokes, and death. Somebody will ask, how does this come along? So, high levels of blood in calcium can damage your blood vessels and lead to your to the heart problem. This is cause high calcium levels cause abnormal heart rhythmias that can lead to heart attack. So the calcium that is coming along here, you find that we have said the body will try to replenish its blood with calcium because the calcium in the body is already low. So at the end of the day, it brings effects now because now it will get hypercalcemia from the PTH being produced, bringing about restoring back the calcium that is needed by the body. So also high levels of phosphorus can cause your blood vessels to harden, which is a process we call calcification. Cause of abnormal hormone regulation, even if your calcium levels are acceptable. So you find also high levels of phosphorus. Nice. A patient high levels of phosphorus will also cause the vessels to harden. However, with the complications, we have some symptoms. D. So adults with mineral and bone pains. Just this way is just like a repetition of what you just covered. The disorder for many years. In children and growing. Unlike in adults, in the early stages of CKD. For example, the growth of a child is well monitored through the milestones. 4 years, and you wonder what's happening. You take them for physiotherapy, still not working. So it comes about as growth failure, and then their bones may be weak because of now the lack of calcium. Now, after being able to understand the signs and symptoms, I guess it just narrows down to now we're able to diagnose it. We can able to diagnose it because we know what to look for. Once you're able to understand what happens, you're able to be able to know also what am I supposed to look for. So, just a discussion on this. First, you have to do a physical exam on any changes of the bone structure of this patient. For example, if the patient was just a normal patient, it's now all of a sudden our patient got to AKI, is now on CKD, maybe heading to transplant. You can able to give a good history of the patient, you're able to observe. And this patient went to this unit while walking, but right now the patient, he no longer walks in his physical examination is very important. Don't ignore this. Study a patient, not just from the lab works, but also from how a practitioner. So another way of diagnosing now the lab works, which is to check for the calcium levels, phosphorus, parathyroid hormones, and other times also check for the vitamin D. So the other happens, but it's also important to check how the bone structure is and also the bone density. An X-ray also can be done for the same, and also we can do a CT scan, either for the heart or for the bones. It will help also to be able to understand what is really happening to this patient. After you have all that, you can be able to conclude, oh, my patient might be suffering from MBD. So what's the way forward? Or my patient, no, is not just suffering from MBD. Maybe it's very important, help a lot. Diagnosis, what do you expect to find? What do you expect to see in the lab works? For one, you're going to find that the so in the lab works, when I test for find that PTH is elevated, calcium, and that one will be able to tell growth growth factor 23. It's also going to be elevated. I'm going to talk about it in the next slide. So if the FGF 23 is also elevated, these are things that are going to be able to help you very much when it comes to the lab work. The bones, we have said for physical examination, or now when you come to the CT scans, the X-ray, they're going to help you. If the bone is abnormal, in one way, you're going to check the turnover. How is the mineralization of this bone? How is the linear growth? Is this child growing? That's what you're going to know. How is the strength of this bone? That one will also help you a lot to be able to diagnose and say that my patient has MBD. So I've talked about fibroblast growth factor 23. What is it? It is a hormone that regulates phosphorus levels and vitamin D metabolism. This occurs by increasing the excretion of phosphorus and allowing the absorption of calcium. So it will be elevated because it's trying to compensate and excrete this high phosphorus. So kindly remember those important markers to be able to diagnose MBD. So after that, the treatment and management. I hope you're already following. Yeah. So the treatment for MBD, it's calcium and phosphate as near to normal as possible and preventing development of severe hyperparathyroidism, and extraskeletal calcification, which may reduce fracture risk and cardiovascular disease. Stage 4 CKD services. So mostly when it comes to the treatment, we really work on ensuring that the calcium levels are okay and trying to lower the phosphorus levels. So we can include, there are some that are called calcium-based phosphate binders. An example is calcium acetate. We have heavy metal salts such as aluminum hydroxide, non-absorbable polymers such as sevelamer hydrochloride. These are some of the phosphate binders that we have in the market. So the phosphate binders have the ability to reduce the ingested dietary phosphorus by 200 to 300 milligrams per day. So when it comes now to the diet, how am I going to be able to lower the phosphorus levels? As a nutritionist, we tend to, now we have talked about the pharmaceutical way of giving the medications. Now, as a nutritionist in the diet, how am I going to work on a low phosphorus diet? One, you can increase the intake of foods with low phosphorus content. So ensure that you are conversant with such foods. Use foods with a favorable phosphorus to protein ratio, at least less than 12 milligrams per gram. Then also boiling reduces the phosphorus by 51% in vegetables, 48% in legumes, and one way of our strategy of for a low phosphorus diet is by increasing the intake of low phosphorus content, which is going to help. Secondly, identify to check on the food labels. It is important to always, whenever I buy a commodity, to check, does this, what are the what are the contents that have been added to this, those do not indicate the amount of this additive, and it is not available in most of the food composition databases. So you find that's the failure from the company that's manufacturing the food. But it's very, very important whenever I'm buying any product, whenever this patient is buying any product, let them be able to understand what is the phosphorus level in this food. In processed food, may reach from 700 to 800 milligrams per day. So we're talking about 200 to 300 milligrams per day. But now you find that food additives have 700 to 800 milligrams per day. That's very alarming. So ensure you're able to identify the phosphorus levels in the products you're about to take. Thirdly, nutrition counseling is of importance too, on reducing the dietary phosphorus intake without affecting adequate protein intake. So that we find that most protein foods have high phosphorus. So how do I be able to accomplish both needs? I'm trying to lower on my phosphorus and I still need my protein. So first I've said you have to get low phosphorus foods, and they are there. They are readily available no matter where you are. You can be able to access them. So also be able to monitor the food additives that are in products. Then boiling is also a point that we have really well tackled about, that it helps in lowering the phosphorus levels. So whatever it is, Is it a legume? Is it a vegetable? Ensure that you can use boiling so that you lower the levels for a patient who has MBD. It's going to be of great help. Another way that we can be able to manage CKD MBD, we can do vitamin D supplementation, which is based on the plasma intact parathyroid hormone and serum levels of now the calcitrol in form of vitamin D analogs such as egocalciferol, which is the calcitrol. I guess they're available in our markets, so you can do vitamin D supplementation. So we have different parameters for the calcium, parathyroid hormone. What are the normal ranges? So that I can be able to know what am I working with. So for phosphate, the normal range is 0.7 to 1.4. So in CKD stage 3 to 5, you'd find it 0.9 to 1.5. CKD stage 5 patients who who are on dialysis, it's 1.1 to 1.7. So in case now you note any derangement from there, you're able to say, oh, my patient has MBD, or my patient, oh, is okay. It's very important to watch out for MBD. We want our patients to have longer life duration, life period. So let us kindly help them to achieve that. Then for the adjusted calcium, this is according to the Renal Association recommendation target ranges. For the normal range, 2.2 to 2.6. For the CKD stage 3 to 5, 2.2 to 2.6, which is also there within the normal range. For the CKD patients who have stage 5 and are on dialysis, 2.2 to 2.5 also. For the PTH, the normal range is 1.6 to 9.9. If in CKD stage 3 to 5, if consistently above the normal range or rapidly rising, consider treatment. Kindly watch for that. So it means the normal range whenever a patient has CKD stage 3 to 5 is also 1.6 to 9.9. For a patient who has CKD stage 5 and is on dialysis, 2.9 to 9, it's a times upper limit of the normal, which is okay. But way above that, kindly consider treatment for that patient. So as we are almost winding up, I said I'm going to be tackling about the bone development and growth. What is really happening? So they can able to understand, okay, my patient I've been able to look for all these things. So how does bone development and growth come along? So the term osteogenesis or ossification are often used synonymously to indicate the process of bone formation. Parts of the skeleton form during the first few weeks after conception. By the end of the 8th week after conception, the skeletal pattern is formed in cartilage and connective tissue membrane, and ossification begins. Bone development continues throughout adulthood, even after adult stature is attained. I really emphasize on this. Bone development continues for repair of fractures and for remodeling to meet changing lifestyles, depending on the lifestyle that you have been adapted to. Osteoblast, osteocytes, and osteoclast are the three cell types involved in the development, growth, and remodeling of bones. So osteoblasts are bone-forming cells. Osteocytes are the mature bone cells. So there's what was there before. Then now we have what is trying to the bone-forming cells. And then now we have the osteoclast, which is the breakdown and reabsorb bones. Important to get to understand that. So bone formation in children occurs by two distinct mechanisms. One, it's similar to what we have observed in adults. It grows as the child is developing. Secondly, it is specific for the pediatric population, that is, modeling of the newborn by skeletal accretion and longitudinal growth from the growth plate through the action of chondrocytes. Very, very important. So I have an image here of an osteocyte, which you have said maintains the bone tissue, an osteoblast, which forms the bone matrix, then osteoclast, which is the reabsorbed bone. Very important. So as we wind up and maybe get to have some questions, in summary, what can we say at the end of it all? What can we say? CKD-MBD is a highly complex process which is caused by derangement of the calcium, phosphate, PTH, active vitamin D, and FGF23. So to prevent the complications such as fractures and cardiovascular complications, measures to target these derangements are used. Some of these measures you find patient undergoes dialysis, which helps to even get rid of the phosphorus. There are dietary restrictions. There are phosphate binders that are going to be used. Active vitamin D supplementation or parathyroid gland surgery. So these are some of the measures that can be taken. Then compliance with therapies can be a problem because of the palatability and adverse effect. This should be checked with patients and alternative recommendations should be given as appropriate. That's just a summary of whatever we have discussed. There is so much interesting details. If you go ahead and be able to understand, I've really emphasized the first thing to be able to know is whatever is happening in the body of this patient. What might have caused this? After I have a good understanding of what mental bone disorder has come along, how does it come along? How am I supposed to look up for it? How am I going to diagnose? How am I going to manage it? Everything gonna be very, very smooth. So thank you very much. Thank you very much. I really, really appreciate your time. I don't know whether there's any questions. Any questions are welcome, but I really appreciate your time. Yes, I hope it was well elaborate. I hope you've understood. At least you've come out of the session with something, even if not all the information. I really trust that I'm up for any questions I'm going to answer for the betterment of my understanding. Yeah. Any questions? Okay, then. So, Milan, over to you. Or maybe somebody has any other additional information. Neema, who else is there? Priscilla, Penina. Any other additional information maybe you have for the people? It's going to be quite informative for us. Milan, over to you. For everybody who have joined us, thank you very much for joining us for this session. Yeah, whether on Facebook or on YouTube, be blessed. It has been a good learning session, I believe, and I hope so. Even for me, I've been learning together with you. And also, we have been doing this, covering different conditions, good different management in chronic kidney disease. Also, we've been able to cover acute kidney injury, which we covered along last week. And we're going to be covering more topics ahead, I believe. We still have renal pharmacology in CKD to cover. Uh, be ready to learn. It's going to be good, it's going to be interesting. I encourage you to always join us. Save it for later if you still want to listen for it. Call mainly to also follow us and listen to the studies that are going in, and I believe we're gonna learn more. So I can see David Joroge saying, thank you very much, David. Actual tablets really help when it comes to MBD, so patients should be advised on its importance. Communication with the patient is very important. Help the patient to understand what's really happening to them. I like it. Some of our patients, our renal patients, you find them they got information, but it's good to clarify unto them what is really happening. Help them understand. There are some who are so elderly, some have given up with life. Kindly help them understand what's happening to their body, and it's not the end. It's not the end. So we're gonna have the treatments are there. More research is going on. They're not done. It's always nice to always follow the KDIGO guidelines. They are updated now and then. So kindly follow them, and I believe you're going to be up to date. Up to date. Let us always be up to date with whatever is happening in the medical field. Guidelines keep on changing, new things keep happening, new research keep being done, and when a new research is done, that one will help with being able to work on something different. Maybe last time you didn't have MBD, you had renal osteodystrophy. Now you know there's MBD. Wow, new information is there, which is of good help to us, and also a challenge to all of us. Let us continue aspiring to know more. And yes, I'm really still waiting on Milan. Somebody reach Milan for me. Still waiting on Milan. Uh, to help us out in this.
Hello, can you hear me?
Yeah, I can hear you.
Yeah, this is
That's
Amondi
okay.
Effie. Amondi Effie. Yeah, part of the panel team. So, Damaris Mudeu, thank you so much for the wonderful presentation we had today about mineral bone disease in CKD patients. It was good to learn how all these nutrients and all these minerals relate to with each other to achieve a common balance. For example, you talked about the phosphorus as a major concern here, calcium as a major concern here, and also the vitamin D, the active vitamin D3. So when a patient has CKD, it means that the balance of all these nutrients is altered. So we must keep on checking our patients' lab work so that we ensure we manage this patient efficiently and effectively. Thank you so much for the wonderful presentation.
Thank you, Effie, for that. Thank you, be blessed. So Neema is adding a point on their studies of mineral bone disease and high aluminium levels on patients undergoing hemodialysis. I've not checked on that. Kindly, we can also check on that. The studies of MBD with high aluminium levels. I really don't know. That was a question, Neema. So Neema was asking if there are studies on mineral bone disease and high aluminium levels for patients undergoing hemodialysis. I'm not sure unless I check on that. Thank you. Thank you. I'm not sure. Anybody has an idea? Mm-hmm. Anybody have an idea on that? So welcome everybody. Milan Amdro. Yes, so over to you. Thank you very much for this opportunity. I've been able to learn a lot. Thank you. Be blessed.
Priscilla?
Hi everyone. Thank you, Damaris, for that presentation. It is important for all of us as nutritionists to understand or know the relationship between PTH, phosphorus, and calcium in relation to the bone disease. And I think it has come out well. So, some good job there. Thank you.
Thank you.
I have a question.
Go ahead, Evelyn. Can anybody hear Evelyn? Personally, I can't hear her, but I can see she's speaking.
I'm saying,
Okay.
can you hear me now?
Yeah.
I'm asking, at what point do we give phosphate binders to the patients with high phosphorus? Patients for the CKD patients, sorry. And then another question: how often do we do the test for the mineral bond?
All right. Thank you. The first question was on how often we give phosphate binders, and then how often do we test for the phosphorus levels so that we're able to know whether the patient has MBD. So, for how often the test should be done, it should be frequently, monthly at most. After the longest duration, I guess I have gotten, I don't remember, I got it from somewhere, I don't remember where. It should take a month. So I guess most of our facilities, maybe in case you're working in Kenya, you are in a public facility. Mostly they do them. Some do them monthly, some do them weekly. So the I'll go for monthly. Maybe I'll ask anybody else to help me on that. Monthly, then phosphate binders. I guess after you have been able to know that this patient has hyperphosphatemia, you need to bind that, but also be able to monitor so that we may not have also hypercalcemia. Maybe somebody can help me with that. Priscilla, Suzanne, Penina, Effie, Lorraine. Yeah.
Um, uh, I think different hospitals have different um, testings. Like for example, in a facility for phosphorus, calcium, we do it quarterly, but the UEC is at least monthly. And if I could comment on the phosphate binders, really, if the patient has uh, high phosphate levels, then you give phosphate binders with meals. And of course, you have to consult a nephrologist so that they can prescribe. So I don't think it would be a decision of a nutritionist alone. And as we had said earlier, that we need to work as a team, a renal nurse, nephrologist, renal nutritionist, so that the management of these renal patients could be, easy. So I think for phosphate binders, we consult, the nephrologist, and then um, for testing, I think different organizations have their different ways. So I think you go with what works for you. Yeah.
Okay, to also add, I would say it's close to impossible to achieve a phosphorus or a phosphate-free diet. Almost every other food that we take has phosphorus. So what you can do is just make sure you take your phosphorus binders before or after meals, about 10 minutes. Or what else you can do is make sure you achieve quality dialysis session. The time for dialysis should be adequate enough to ensure the mineral balance, the electrolyte balance. Thank you.
Thank you for the responses. Yeah, I don't know whether Green is still around. I don't know whether she's.
Okay, we thank you, and thank you, Damaris, for the wonderful presentation. Let's meet again tomorrow and see how the presentations go. So we have Naima doing kidney transplant tomorrow. Having said that, I think we have very interactive session today, and have a good evening.